So good evening to everybody who's present here, and I really appreciate your presence. I am both honored and humbled to be part of this course, to lead this course where we have all stalwarts, and I feel like a tiny speck, and I intend to learn a lot. We have an interesting program of talks along with a nice keynote lecture, and we hope to make it interactive. I have just one request to all the faculty because we have an 8 minutes keynote lecture also, the AIOS keynote. We will try to wrap up our talks within 10 minutes so that we have some time for discussion. And without much ado, I think I want to start with my talk, and which is more on what is a very hot or a controversial topic. Should we or should we not implant an IOL in an infant? And what does evidence say? This is not what I think or what anybody else thinks. This is what has been mainly published and presented, and what is it today. So I think for us it is very, very relevant because we are one of those countries who has a large burden of pediatric cataract, including infants, although we do see a lot of delayed presentations. And technically we all understand, and we saw those beautiful videos even in the previous session, that we are all getting better. We have better access to technology, techniques, and so much exposure to learning. But functional outcome is something which probably is a lot of it is not in our control, and therefore we are lacking behind, particularly when the child is below 1 year or 6 months when they undergo surgery. So if we are to say why should you implant an IOL in an infant eye, the most important thing is to give early rehabilitation. Even if the child could wear aphakic glasses, the partial visual input that is always present without any refractive correction is something that cannot be given by aphakia. In our country, most of the times contact lens practice is not practical, especially in infants. And obviously we need to correct the refractive errors in a growing eye. But then again, why should we not implant? I think in my mind the most important thing is technical difficulty or surgical difficulty in doing this. If we feel during surgery that the eye is too small or that there was too much manipulation and you could not do an in-the-bag IOL implantation, that is when I think nothing else should matter. All these points should stop, and this is where we should change over our strategy and leave the child aphakic. But these infant eyes, as we know, also have a high risk of exaggerated inflammation, glaucoma, and visual axis obscuration, whatever we may or may not do. And it's very, safe to say that above 2 years of age, and now it's probably even above 1.5 years of age, it is not so much of a question whether or not to implant. It is only in the children below 1 year of age and unilateral cataracts at any age, which pose a problem because that's where you always want to implant an IOL. Secondary IOL also is a part of our strategy, because when you talk of infant cataract surgery, you must, if you are leaving it aphakic, then you have to think of what you will do when a secondary IOL situation arises. And there are many options for that. If we are to do a primary IOL implantation, it is very well agreed in literature that there has to be a posterior capsulectomy, capsulotomy, capsulorhexis. That means posterior capsule management with or without a vitrectomy. And without vitrectomy will only work if you are doing an optic capture in the eye. Now this is one of the landmark studies that has been published recently. Dr. Meenakshi, Dr. Varshini, Dr. Jagatram sir, please join us on the dais. So this is one of the landmark publications, and every year we see at least 1 or 2 articles coming out of this study, the infant aphakia treatment study, which was conducted in the US for children at least, below 7 months of age at the time of surgery, and all of them had unilateral cataracts. Now they have recently studied up to 10 years of follow-up. Randomly, children were allotted to primary aphakia and contact lens or primary IOL. But we need to remember that these were all unilateral cataracts and below 7 months of age when they were operated. What they did find at 10 years follow-up is that the pseudophakia group had 72% of them required a second operation, either for most likely for a visual axis obscuration, but also IOL exchange. And this is something which I think may differ from culture to culture, country to country. In our practices, we don't do so much of IOL exchange, particularly for pediatric pseudophakia so early in their follow-ups. But yes, visual axis obscuration is something which they will need. So they need more surgeries, but the aphakia group eventually needed more secondary IOL operations as they went down the follow-up. So that is something we need to keep in mind, that they will someday need a secondary IOL implantation. So based on this study, they conclude, and they have given a recommendation which has also been followed by the American Academy, that when you are operating a unilateral cataract below 7 months of age, then IOL group performed worse than the aphakic group, and therefore do not implant an IOL. It is very well and it makes sense. But in our scenario, this may not always be the case, because particularly unilateral cataracts, if they do not have a microphthalmos, if they do not have a microcornea, and if there is sufficient surgical experience, it may be a point to implant an IOL. There have been long-term studies from L.V. Prasad regarding unilateral and bilateral cataracts in infants, and they have shown good results also. Now the same study, the infant aphakia treatment study, where they gave free contact lenses, Silsoft contact lenses, and home delivery and home fitting of these lenses was done. And still they found that when you compare the costs, the primary IOL implantation was only about 5% more expensive than aphakia and doing this kind of a contact lens correction. But when you look at contact lens, the overall costs eventually were more than double as compared to putting in an IOL. So obviously that's a factor. So again, like I said, if it is not a microphthalmos, if it is not a microcornea, unilateral cataract, if you can do a good surgery, may warrant a primary IOL implantation. So based on this study and others, the American Academy also has given an implant recommendation. And I think it is fair to say this from the podium, that as a general rule, when a child is below 6 months of age, there is a very high incidence of visual axis obscuration. Their growth is going to be unpredictable, and they are going to need many more secondary interventions. And therefore, you have to be very, very, very careful if you are thinking of an IOL implantation. Another published study, the TAP study, or the toddler aphakia pseudophakia study, it looked at bilateral cataracts between 1 to 7 months of age. Now again, a completely different ball game, and we see more of these bilateral cataracts, so much more. There they found that visual acuity was similar whether you kept the child aphakic or pseudophakic, and obviously IOL does increase the risk of visual axis obscuration. Glaucoma was comparable. So they again recommended that you may not want to do an IOL below 7 months because they need more surgery for VAO. Now this is all very good because all of these both were in the US. Now we look at our population, and our means a lot of part of the world. It's not just India or Asia. This is applicable to a lot of the world. Below 2 years, when there is a bilateral cataract, there is no randomized clinical trial, and we published this few years back, where we looked at 5-year postoperative outcomes, bilateral cataracts below 2 years of age, bilateral aphakia with spectacles and or contact lenses, and bilateral pseudophakia. And this randomized trial was conducted with a very, very rigorous methodology, and we looked at these complications: glaucoma, VAO, inflammation, cell deposits, all defined based on published criteria. What we did find is that the pseudophakic group had more posterior synechia. Well, yes, more visible posterior synechia, because the aphakic might have mid-peripheral synechia, which you do not see unless you do a UBM for these eyes in every case. But when you looked at the glaucoma incidence, it was comparable, and even the visual axis obscuration was comparable at 5 years. So yes, a little bit higher incidence of posterior synechia, but otherwise it was comparable. Complications. What stood out is that the rate at which ultimately at 5 years they both reached the same endpoint in terms of their visual acuity, but the pseudophakic group reached there much faster as compared to the aphakia, which had a slow climb. And I think in our population, who are going to give up on any therapy, any treatment, if they don't see a visible, tangible benefit, this is very, very important, that if you can give a faster rehabilitation, and without glasses, without contact lenses, at least partial visual input, then it is going to be a much more successful treatment. Now when we talk of primary IOL implantation in infants, I think this is what I do, and I recommend most of us should do, is if you can do like some of our experts, all of our experts sitting here will say that, oh, it's very easy to do a manual anterior posterior axis, do a vitrectomy and put an in the bag IOL. But in children below the age of 1 year, it's not always that predictable. So what I often do, particularly below 4 months of age, I perform a manual anterior capsular excis. I will put in an IOL in the bag, your choice of IOL, 3-piece or single piece, but hydrophobic acrylic would be without any commercial bias, my recommendation. And then go in with a 23 gauge vitrector and perform a capsulectomy vitrectomy. So therefore, at least you have that IOL in the bag. You don't have to worry about an inadequately sized posterior capsule opening. Another technique that we are finding more and more useful in many situations, but particularly in pediatric cataract surgery, even in infants, is that of optic capture. Now yes, this is skill dependent and takes a learning curve, but when we start in older children, 5 years, 6 years, then start coming down, perform a manual, or if you have access to a femtosecond, even better, femtosecond anterior and posterior capsular excis, and you can do an optic capture even through a femtorexis. Put in a 3-piece foldable lens in the capsular bag, and now as we can see here, the entire optic is being slid behind the posterior capsular excis margin. Now the advantage of optic capture is twofold. One, you don't need to do a vitrectomy because there is complete fusion of the capsules, and therefore your risk of visual axis obscuration is very, very minimal. But more importantly, also we realized now that it actually locks the IOL in its position. So once the IOL is captured, it's a noose around the optic haptic junction, and therefore it is not going to move. So in both ways it makes total sense to perform an optic capture. Again, a skill-based procedure, but worth learning. And we publish 1-year results, and we are almost ready with our 5-year results of the same study now, where we randomly did in the bag IOL or an optic capture. And in both groups, 50% of our children were below 1 year. This study was not just for infants. And until 36 months follow-up, we found that the optic capture group, there was no visual axis obscuration, even when we did not perform a vitrectomy. And remember that 50% of this population is below 1 year of age. So yes, it does delay or reduce visual axis obscuration. And in terms of glaucoma, again, VAO and glaucoma were completely comparable between the groups, so were the inflammatory deposits. So I think it can be achieved in most eyes, older obviously, but as you keep getting practice, even in younger eyes, and this is a technique we should learn. I was recently asked that why would you want to avoid vitrectomy? I think it's because it's an additional procedure. Not everyone has the machinery, not everyone has the expertise to perform a good anterior vitrectomy in every part of our country. So I think with that, the only thing I would like to say, infant or not infant, any small eye, corneal diameter, microphthalmos, or like I started my talk, if in your surgery something has gone wrong, if you have damaged the iris, traumatized the eye, please pack up and leave the child aphakic. We will be doing much more good than harm. Thank you.
I think Jagat Ram would appreciate your comments on IOL. Your guidelines to all us Indian colleagues will be very important. Would you, what are you doing yourself, and what would you recommend in general, very briefly?
I think I will recommend what Dr. Vaishali Vasavada said, that ideally speaking, we should put IOL implantation more than 6 months of age. Almost same thing what you are doing, but selectively I have also used in younger than 7 month age. 7 month age is the study which you quoted. So that is what I will say, that is the guidelines for everybody. Whereas selectively, if we are doing anything, that has to be proved by the scientific literature.
Thank you, sir.
Yes.
Do you take any special precautions to prevent vitreous prolapse when you do primary posterior capsular access? Because you said you avoid vitrectomy, and most of the times in my hands vitreous comes when I do a PVC. So do you take any special precautions to prevent vitreous loss in PVC?
So again, like you said, this is a very relevant question. That one, you are candid enough to accept that you rupture the vitreous more often than you think. So I think first thing is, in technique, what we do at all surgeons at our centers, we make a bent, a slanted cystotome, and we sort of swipe it up. We don't do a vertical puncture ever. So it's more upward puncture, and then we use microrhexis forceps to pull it up. And the other thing is that a lot of times we don't even know that we have ruptured the vitreous. So we must use preservative-free triamcinolone after doing a PCCC to confirm whether the phase has been ruptured or not. So yes, it's more of a detection problem. I think all of us do it. And prevention would be by using more heavy viscoelastics like Helon 5 or no financial interest. And some people also inject it through the opening once they do. But be very careful in the amount that you inject. Any comments from the panel?
I
Anybody?
think the additional to what was told is the focusing. You should be able to use both your hands, focusing crisp every second of the procedure. If your focusing is not good, and you really need a good microscope with a good glow, red illumination, you can generally avoid rupturing the capsule. But if you rupture, there is no shame in stopping there and then perform anterior vitrectomy and then continue capture. Capture can be done even after anterior vitrectomy because there are two main advantages, she told. One is the stability of the IOL and other is the visual axis obscuration. So vitrectomy we had to do it, so we did it, but at least the stability will be guaranteed with capture, unlike the in the bag, which is vulnerable to capsule contracting forces. So it doesn't matter if you rupture, don't worry about it. Be ready with anterior vitrectomy and still continue performing PCCC and capture it. But slowly, it's with the time and experience, it's not difficult.
The advantage of capture is you don't have to change the IOL power for the circus and bag.
No,
So-
we fix up the power accordingly only. We planned a capture. We initially aim capture, and therefore we have an appropriate power, half a diopter more, generally speaking.
How about starting the rupture with the capsule tear with forceps or instead of the system?
You can, but with the puncturing with the forceps, it's not very sharp like a needle. So you have to do vertical thrust, which is lethal, which is bad. So you kind of swipe and take the capsule along with it, lift it up so that it is pulled up, and then it tears in that process. It stretches and pulls.
Hello, sir.
Yeah, I think you
sir-
decide the time and we'll.
I think we take this last question and then I would invite Jagatram sir to set up his laptop meanwhile.
That's level of anesthesia. Does level of anesthesia helps in at that particular point? We can tell the anesthetist. or-
Yes. I think.
Is there
but
any role? I mean, is there any
yes,
role?
there is if the deeper the plane of anesthesia, the better it is. And I think this goes for the entire surgery. Even when we are doing an INA, you don't want any bulges. So in general, when we are performing a surgery, we know that it's going to last, let's say, half an hour, 45 minutes. So we generally ask our anesthetist to put them deep prior to what we start. And we will tell them that, okay, we still have 15 minutes to go, so don't start lightening. You have to inject, please inject, but don't lighten the patient.
Okay, sir. Hi, best.
So I now invite, it's my honor and pleasure, and I'm really grateful that sir has agreed to be part of our course here. And he'll be talking to us about tips and tricks of performing surgery in these eyes.
Yeah, go take your time.
इसमें ना स्लाइड एक एडिशन किया है इसमें।
अच्छा इसमें ये वाला दिखा दूँ
ये
ये वाला अच्छा ये वाला दिखा दूँ।
I think while we are waiting on the posterior capsule rexus, I think I would suggest to practice it in older children first, before you take up the younger ones, and be proficient and get a confidence in performing PCCC, and inject the Helon GV-like material on the peripheral capsule more rather than in the center, because if you put it in the center, it will become concave. And we really want to stretch the capsule. So keep the injecting in the sides, all 360 degree, and just a little in center and towards the endothelium so that it descends down. Don't put too much in the actual area of the rexes that you're going to fashion. Yes, sir.
First of all, I am thankful to Dr. Vaishali Vasavada for giving me this opportunity. And I have these children coming to me with visually significant cataract, and we have to see each of the child very carefully. And my topic is surgical tips for surgery in small eyes. While I got this topic, initially it was some different topics, but ultimately I found that this is the topic. I have to speak on the surgery in small eyes. Then I thought that what is the small eyes? I divided it into two: small eyes of infant with normal growth. There is a group of eyes where eyes are small, young children, infant, where growth is normal. But there are other where there is a limited growth, such as those having microcornea, microphthalmos, or some of the other issues, associated conditions are there. I will show the example also. So a small infant eyes with normal growth. There are several issues because eye is a growing eye. Whether IOL implantation should be done or not done, or what is the age, till what age we should do IOL implantation. It could be technically challenging. Of course, post-operative inflammation and glaucoma, there may be higher chances. Then whether to implant IOL or not, the general consensus in pediatric of the pediatric surgeon is to implant IOL in normally developing eyes wherever possible. Till now, our this as per literature is 7 months retrospectively, because even previously we implanted IOL in younger children than 7 months. But that is the agreed thing, that 7 months or more, I think it gives equivalent or better result. But 7 months or less, there may be number of publication, number of the post-operative complications may be higher, but maybe after 5-year results, maybe visual outcome is same. So what I do selectively, when I say that selectively I implant IOL in children even less than 7 months in normally growing eyes. If child has axial length of 17 millimeter or more, and if the diameter of the cornea is 9 millimeter or more, these are the children where I will like to implant IOL. If it is 8 millimeter corneal diameter and axial length of globe is 16 or 16.5 or less, I don't implant IOL. That is one. Although it is these are some of the studies which are published in the literature, IGO and European Journal. We have published of the children in the first 2 years of life cataract surgery, and in the infant. Conclusion of those studies were meticulously performed primary IOL implantation and primary capsulorhexis and anterior vitrectomy in the first 2 years of life is safe and effective for aphakic correction. This is a small video I will like to show infant's eye. This is a 10-month-old child. I think no contraindication. Usually problem is in the child less than. So this photograph was taken. Child was smiling. So this is some natural smile. And while you dilate, you have to dilate each of the eye where you want to do cataract surgery, because anatomical this is extremely important, because you may find PHPV, you may find some of the other issues, posterior lenticonus, if you do not dilate, or there may be several of the several of the points which you will find while you will dilate the people. So here this 10-month-old child, during surgery we realized that this posterior capsule was less. Actually it was a posterior lenticonus. So you have to be, there are classical lenticonus also where we have done surgery. So here it is up to you whether you want to do primary posterior capsulotomy before or after implantation. What is most important is to secure the IOL in the capsular bag and then doing posterior capsulotomy. Several times I do it most of the time before, but here in this case I have done it afterward because I wanted that IOL should be in the capsular bag. And I have a child which I have shown this example yesterday also. In 1997 I operated this child infantile cataract and I have followed this child for 25 years. That point of time I did primary posterior capsulotomy and anterior vitrectomy. That was the start anywhere in the world. And this child after 25 years, bilateral pseudophakia, 20/20 visual acuity, and grown up now doctors. He has completed MBBS. So you have to follow them. I mean to say, you don't forget once operate and forget. That is just the first step. And then this is another small video. Particularly beginner, they have to stain the anterior capsule with the trypan blue dye, but it is not must for those people who have excellent experience. A hydrodissection and removal of the cortex from the capsular bag. And then after removal of the cortex, primary posterior capsulotomy. Then is the important what is the size, should be the size. It should not be very small. I think probably in this case it is 3 millimeter or so. Ideally it should be 3.5 millimeter or more. And then limited anterior vitrectomy and implantation of IOL into capsular bag. Most of the time I do capsular bag implantation, and some of the cases I do even posterior capture of the optic. Small eyes with the limited growth, axial length, small axial length but normal globe. These are the patients where normal growth children we may implant IOL, but axial length should be 17 or more. If there is a microcornea, corneal diameter 9 millimeter or less, or axial length is less, then we may not implant IOL. We have found several of the children with persistent fetal vasculature where there may be small cornea and microcornea. So I think these are the patients where you may not implant IOL. This is one of the child. I will show the video where axial length was less and cornea was small, where you may not implant IOL. We have published that in European Journal of Ophthalmology. This is one child which is published in Indian Journal, where even pupil was also very small, but it was left aphakic. Though favorable outcome can be achieved with IOL implantation in the bag with persistent fetal vasculature, eyes with the microphthalmia and microcornea should be left aphakic. This is one child where persistent fetal vasculature was there, but this was with microphakia. It was because ultrasound was done before, so we could detect that there is a stalk. If you do not do ultrasound, in such cases you may detect it operatively only. It was a very thick anterior capsule. Capsular bag was small. It was a just microspherophakia type of picture. And with great difficulty, rhexis could be completed. And this membrane, this was the posterior capsular membrane. Primary posterior capsulotomy was done, and adequate capsulotomy was done anterior and posterior, and it was left aphakic without IOL implantation. Very few studies have shown the IOL implantation in these eyes, whereas never take risk and do not implant in these microphthalmic eyes. These are the definitely cases where you should not implant. These are eyes where there is a microcornea and microphthalmos. There will be complication in these children, whereas all these children never implant IOL in these children, and there will be complication like glaucoma, such as one of the child has only 4 millimeter and other eye 4.5 and 5 millimeter cornea. It was left aphakic. Take home message is favorable outcome can be achieved in eyes with the microphthalmos and microphthalmia using meticulous surgical technique. In the present era, those children where eyes are small but growing eyes, one may implant IOL. So thank you very much for giving me this opportunity. These are the children, young children who are growing up, but I have maximum follow-up of 32 years also. I have followed these children where I have implanted IOL. Thank you so much.
Thank you, sir. And before we move on to the next talk, if there are any questions, we can take 2 questions from the audience. Okay. If not, sir, I have a question for you.
Yeah.
I saw that last video where you used the Malugin ring to dilate the pupil, and this was a microphthalmic eye. So for all of us, we have an option of using these ring expander devices which are more single piece and little bulkier versus the hooks. So what would your advice be, and what are the challenges in using such expander devices?
I think I use most of the time, if I have Malaysian ring, I use it in these small eyes I have used, but sometime even if it is a 360 degree posterior synechia, I may use even hooks. But I have most of the time I have used Malaysian ring in these children.
Vaishali, any comments?
I think Malaysian rings are definitely a little more bulkier to put inside and take out.
Madam, any comments from me? So yeah, I think I am more on the hook side, because like sir said, one, we are more familiar sometimes, but also they help you to break synechia, and a lot of these may have mid-peripheral synechia which you can't actually see. So I think that was just one point I wanted to highlight, and in the interest of time we move on. I would request all speakers if we can keep it around 9 to 10 minutes so we have some time for discussion with the keynote.
No, we are all looking forward for your keynote address, so we will be very conscious of that. This is my and recognize the contribution of my REH team and Dr. Deepa Agrawal. I'm going to select 3-4, but I saw fetal vasculature and Professor Jagatram has done extensive work on it, so I've just hidden those slides for the moment. If you have the time, we will discuss that. But there are many spatial situations, but in general, whether it's a spatial or congenital cataract, we always perform EUA, not only pre-operative evaluation, but we continue doing it post-operatively at periodic intervals in children where we cannot assess the glaucoma part and many other things for our academic interest, the growth of the eye and so on. So EUA has been our kind of a sheet anchor in our management, and the sonography B-scan to detect those things, the lentiglobus stuff, UBM, and all of these are kind of has become a routine in general, and if there is any spatial situation, we do that. We have used intraoperative OCT only for a short time. We do not have that luxury, but that also is something we can keep in mind. But this is one condition we described long time ago, and that pre-existing posterior capsule defect is generally the end product of lentiglobus, or which used to be called as lenticonus, where the capsule gets stretched and thing. And we described this in 2002, a fishtail sign, where you can see, and Dr. Daljit Singh had described this dot sign, white dot sign, earlier to what we described. So thank you. But this is something which alerts you for that kind of thing, that there is a defect in that posterior capsule. That will make you anticipate the problems. And this is the sort of eye where you actually can suspect a defect and remove the globe, and you might see that. Here we see the white dots, but not actually the sign. So bimanual approach is always preferred in all cataract surgery, but particularly this collapsible sclera in children. So that will maintain the contours and pressurize the system, and we'll have an access to 360-degree lens material and capsular phoresis. So we do that, and when we soft, we inject dispersive viscoelastic, but you can see the defect in the posterior capsule, and I suggest and recommend very strongly to consider pars plana vitrectomy versus limbal. I've done limbal for 40 years, but now for a few years now, I realize the safety and the efficiency of the pars plana approach, where you do the same thing except that it is 2 millimeter away. In the children, 2 or 2.5 millimeter away from the limbus, and irrigation from the front of the eye as you are doing. So it is just like a bilimbal vitrectomy, but don't get bogged down. The vitrectomy is only 2 millimeter away from the limbus, but it is more effective in removing and safer to the posterior segment. And once you do that, because this margin has been there, it's fibrosed, and it is quite strong. You'll be surprised. So that opening in the capsule without PCCC, it acts like a PCCC, mechanically strong, supporting the lens in the bag, and you can have a choice of your lens. But notice so many sutures, even the paracentesis sutures, we did that, and then we want to suture every millimeter of that incision. This is 3.5 or something like that incision, and these are 1.1 millimeter incision. Suture them because they are collapsible, they are crying, they are squeezing. But other important thing is to remove them as early as you can, but keep it as long as you want to. So in general, we do an EUA in 3 to 4 weeks time of such patient, where we remove it. Because why we want to remove it? By the time the incisions are secure quite adequately, and we don't want to continue with the astigmatism. These sutures will produce astigmatism. Even one suture can produce 4 diopter of astigmatism if you sort of make it very tight. So do not keep it too long, but we want to keep it for the safety for some time. So that's what it is, and then you continue doing that. This is another case of preoperative. We had a slit lamp attachment at that time. there. And these are the lentiglobus stuff, and you will see that coming up in a, this is I think a picture. Right. So this is the lentiglobus part, but that part here has produced already a defect. If you wait enough, it will be a defect like this. So these are the conditions which really need a lot of thoughts and planning beforehand, and you should have plan A, plan B, and plan C every time, and try to convert that defect into some kind of a strong margin. If ideal would be to circumvent and encompass the entire two defects or two thin areas and produce a very strong PCCC, a bigger one, but sufficiently strong to support the lens. So that's what I'm trying to aim here, and I'm taking my time, and it took a lot of time. Now these are attachment of Wegener's ligaments, and patellar fossa is very shallow in these infants, so we need to excise rather than vitrectomy. Vitrectomy can be quite traumatic to the vitreous face and the base if not done adequately. So sometimes cutting it with scissors with no turbulence in the vitreous time can work, but you need to be very careful. And now, because I was lucky to produce a good strong margin surrounding those defects, I had the decision to put a IOL in the bag. I would have put 3-piece IOL now in this time. This is a little older one, but 3-piece will have an advantage to capture or reverse capture if the capsule gives way. But it worked out well, and at the end, always, whenever the posterior capsule is open, inadvertently or pre-existing, check for the antivitreous at the very end. And sometimes it's very embarrassing to see a strand of vitreous going to the incision, and you notice it later on, a little peak, and you say, okay, but that will produce a detachment 20 years later. When I was trained in 70s, we had a book, and it written that all the children cataract will develop detachment after 20 years, 25 years. Why? Because these vitreous strands, it looks so innocuous. They gradually keep pulling the vitreous base and really produce. So vitreous in front of the posterior capsule is detrimental to the eye. It's a matter of time, tomorrow, and that tomorrow could be any time. So make sure that you confirm that vitreous residual left over into the chamber. If you have the time, I can take up the other special, okay? But tell me when to stop.
Yeah, we can take up one more situation.
So this is not uncommon, and as Professor Jagatram highlighted, these kind of conditions are more common in unilateral cataract, and that's why there's a cataract. There is a local pathology, fetal vasculature, and this plaque, I believe, is also a form of frusta of the fetal vasculature. We see the mittens of dots, but this is an exaggerated EMT process. Epithelial mesenchymal transformation occurs in these, and that's where the anterior hyaloid vasculature, vasculosa lentis, was there, and that's why there's a plaque. And this can be a thicker fibrotic like this, or it can lead to the defect as you saw earlier. So what you saw just now was a plaque peeling, and then you have the chance to consider implantation. You don't need to. And if you do not have expertise or experience, do not put the lens. Slightest doubt, abandon the lens, let the other person have a chance or later on in the life. But if the plaque is too big, you need to fashion the opening in the middle and leave behind the peripheral, because if you try to detach those big ones, you may produce more problems. And if you leave behind a peripheral capsule, you can utilize for the supporting the lens. So what I'm doing now is I made a nick in it and injected Helon here, not Helon GV, as a simple cohesive viscoelastic. And then I'm going to use the scissors, and I use Greischeber scissors, no interest of money, but they are wonderful retinal scissors, and you need to make 2, 3, 4 parasynthesis to suit the ergonomics. You do not twist your hand or wrist to cut that. For example, I can cut easily by twisting my hand, but I make another opening, I'll make a 4th opening if necessary, but make sure that you do not stress these capsules and create a sufficiently large opening into the eye. and then you make sure that you remove it and there is no vitreous attachment. We thought that there is a vitreous attachment, and we perform anti-vitrectomy. So that's how you manage. And once again, we strained the triamcinolone, and you saw that. It looked pretty good, but notice that there was a vitreous. So that's the value of staining the vitreous. Do not leave the eye until you're finished with the staining, and then you need to deal with that. If you see the vitreous in the chamber, you cannot leave behind. So I would have done now pars plana, but that's what you're. We then became greedy. We removed the vitreous, and now we think, let's make a decent opening so that we can have a good clear axis, as well as we can put the lens. So we put the lens in the bag, and then we are okay. So you need to take time, and we found and published in the JCRS some time ago that it gives a good result depending upon the strategy and the size and the location of the plaque there. So I think
Yes, I think we can
that
conclude.
should be enough with the time. So Professor Jagatram, I would value your in the plaque. Any other comments or anything that you would like to
I
share?
think you have adequately two type of plaque. One is which is avascular plaque, where already there is no vessel, but there is a plaque, the type of plaque which you removed in one of the case. That is one where you have to lift with 26 gauge needle and remove it, and then after implantation you can do primary posterior capsulotomy. There are other plaque which is a vascularized plaque. These are the plaque of PHPV because we see very commonly these PHPV. So there you have to cauterize that plaque and do the primary posterior capsulotomy. So these are the two plaque I know, but even avascular plaque, they are could be the those PHPV where vascularization is not there, where regressed
I
type.
think so. I believe that the posterior capsule opacification present at birth congenitally, or it develops a little later on, becomes visible, so has to do something with the vasculosa lentis, remnants. They persist. And there are many factors, and one of the factors we researched was the collagen factors. There are 4 collagen factors which allow sort of stop regression and let the vasculature persist. And this could be a spectrum of condition where extreme is that fetal vasculature posterior capsule defect already present, and the list is a thickened little plaque, mitten dots, this kind plaque, that all are probably are a same disease.
Before we move on, just one last comment. I think for us, young, lesser experienced surgeons, I think 2-3 points based on the last 2 presentations. Number one, as we saw in both presentations, make only as many small incisions as you need. Small incisions, we may make 1 mm, 3-4, but only enlarge it to a 2.2 if you, or a 3 or whatever, if you think you have reached that stage where you want to implant the IOL. Sometimes we just, as a routine of being an adult cataract surgeon, start off doing that. I think that is something which we may not need. The other thing I wanted to highlight was, which was very rightly showed by both, when you have a plaque or something, when you are stretching too much, especially with plaquey capsules, we don't realize that these late dislocations which we are seeing even in adults, if you keep stretching and pulling, use scissors or vitrectors instead rather than pulling too much, because we don't know what's going on with the zonules in the periphery. I think these were the 2 points I wanted to highlight, and again it's my pleasure to invite my very dear friend but an expert on visual rehabilitation and particularly neuro-ophthalmology, Dr. Vaishali. And I think the first 3 were more about surgery and how you do, but the more important part of how you make good of that surgery in the time to come is now the next 2 talks. So I would urge you all to pay attention to newer ways of rehabilitating children.
Thank you, Dr. Vaishali. Thank you so much for inviting me to be a part of this IC. After those wonderful videos, so basically at the end of surgery, we have the eye is healed, the IOL is inside. So my talk is pretty much on taking off after the surgery. So achieving a good visual outcome requires early surgical removal of the cataract, of course. but consistent optical correction of both the aphakia or the large residual errors, because as you said, now we are implanting pretty much 7 months onwards. So there is a large residual error, especially in unilateral cataracts, and then compliance with amblyopia therapy. So refractive correction of aphakia and pseudophakia can happen, as Dr. Vaishali had described, with glasses, with contact lenses, and with secondary IOLs. I won't go into this because this has already been described in detail, but pretty much we all agree that now we have younger and younger children with who are pseudophakic with a large residual refractive error, or aphakic if they are very small eyes who need to be rehabilitated. So spectacles provide satisfactory correction for bilateral aphakia. We give near dominant glasses younger than 3 years of age, and once the child starts reading, shift them to bifocals or progressive glasses. We also need to remember that many of these children have other facial abnormalities as well. They may have low set ears or a flat nasal bridge, because of which the glasses don't fit. Sometimes they're wearing hearing aids as well if they have multiple systemic problems, and they may require modifications of their glasses to provide the refractive correction. So in pseudophakia, primary implantation of IOL in even the youngest children with an undercorrection of 6 to 8 diopters implies that nearly all infants will have an amblyogenic residual hyperopia, especially those who have been operated for a unilateral cataract. As Dr. Vasavada said, a dilated refraction or a repeated EUA is often necessary in these patients. Near dominant glasses are given earlier. We prefer contact lenses in cases of significant anisometropia, and bifocals and progressive lenses are started post 2 to 3 years of age. Contact lenses, a wide variety is available. As we've already seen in our clinical context, the acceptability of contact lenses is a major problem. I generally find that parents who themselves are myopic or have had surgery themselves and are comfortable with contact lenses are much more comfortable with using it for their children as well. Silicone contact lenses combines the best features of hard and soft contact lenses. The power available is from +12 to +32, but they're expensive, and especially the last 2 pandemic years, there was a major problem with supply, so we always need a backup plan for these patients. So now coming to the actual part of my talk. So amblyopia therapy, children with congenital cataract have a stimulus deprivation amblyopia, which is forms less than 3% of all amblyopia. There are no randomized control trials conducted on the management of this kind of amblyopia. Generally, these patients are excluded as it's considered much more severe and resistant to treatment. Now, if we look historically, patching has a very, very long history. There are some descriptions of patching being even suggested in as far back as 2000 years back. Erasmus Darwin in the 1700s, he's grandfather of Charles Darwin, suggested first fusion exercises for strabismus and for correction of strabismic amblyopia. Pleoptics was devised somewhere in the mid 1940s, and it was considered so difficult to overcome the suppression in these eyes that special vision schools were set up in Germany, where children would be admitted and they would undergo this therapy for weeks to months at a time in the 1950s. So this is just goes to say that mankind generally has been struggling with treatment of amblyopia, with patching being the only long-standing treatment which has stood the test of time over the last 1000 years or so. The gold standard for patching is total occlusion to form in light. The infant aphakia treatment study used 1 hour per day per month of age till 8 months of age, followed by 50% of waking hours. The amblyopia treatment study, however, which did not include stimulus deprivation amblyopia, they have noted that moderate amblyopia, 2 hours of patching plus 1 hour of near work works equally as well as longer hours of patching. In severe amblyopia, 6 hours with 1 hour of near work also is extremely effective. Atropine penalization of the sound eye may be combined with plano lens, especially when the child is hyperopic in the good eye. Generally is used in children who are non-compliant with patching or who have failed several attempts at patching with occlusion. So as mentioned, compliance with patching is the major issue, and it is the major issue in unilateral congenital cataract. The monitored occlusion treatment of amblyopia study has found that the actual amount of patching which happens is less than 50% of the prescribed hours, and there may be a ceiling at somewhere around 4 hours. So you can prescribe 6 hours, you'll still get 4 hours. You can prescribe full time, you'll still get 4 hours. And again, historically, there are reports that they used to glue the occluder to the skin around the eye, and there are even suggestions of suturing the eyelids closed for some children who were extremely non-compliant with patching. But now today, in a more gentle age, it has been suggested that educational intervention, this includes showing videos, counseling, cartoons, rewards, as well as maintaining logbooks as to the duration of patching, are very helpful in increasing the compliance from less than 50% to about 80%. This photograph is of a child with an occlusion dose monitor, which has been used in several studies to monitor the actual hours of patching which is being done. These are thermal sensors which are embedded on the internal and external surface to detect the duration of patching. Liquid crystal glasses, some of you may have some experience with them. They were launched in India as well as a couple of years back, didn't really take off. So they are normal glasses, the refractive correction can be incorporated in them. They're electronic controlled occlusion. So basically there's an intermittent flickering, the patching doesn't happen continuously. The glass turns dark and light on and off, so the child is not even aware that the patching is happening. And it can be titrated, the on-off flicker can be titrated depending on the depth of amblyopia and the age. It's obviously cosmetically much more acceptable than a patch. And studies with, small scale studies have shown that it's comparable to patching in moderate amblyopia. So coming to the newer therapies, these include perceptual therapies, dichoptic therapies, and virtual reality based therapies. So perceptual learning is based on the principle that practice makes perfect. So it's a series of tasks training the amblyopic eye to detect certain spatial frequencies, and repetitive performance of the software based visual tasks improves the visual performance by inducing plasticity in the visual system. These tasks include gabor detection, vernier acuity, letter identification and noise, etc. The Revital therapy system is FDA approved, and the company claims a 2.5 line improvement and 100% improvement in contrast. However, the main complaint which patients have, one, it is quite boring and difficult to stick through the entire duration because they're very repetitive tasks, so not suitable for young children. And the outcome measures which the patients achieve don't really transfer to real life. So the patient, theoretically, they do read a line better, but don't really feel that there's any practical difference. So these are Gabor patches. They're basically gray gratings, and these are the kind of tasks which are offered during this, where you identify which is the darker image, which square has the image, which image is shifted, and so on. Coming to dichoptic therapy, all the previous therapies which we have described is basically just stimulating the weaker eye. Dichoptic therapy basically believes that there are inhibitory signals from the stronger eye which suppress the cortical inputs from the amblyopic eye and prevent binocular cortical function. So you can unlock this latent binocular visual function by presenting independent visual stimuli to each eye, which requires the integration of the two images. So the image which is shown to the amblyopic eye is of higher contrast to compensate for the decreased contrast sensitivity, and gradually this higher contrast is reduced as the vision binocularity and contrast improve. It's definitely fun, shorter duration, and may help in improving compliance. Some movies have also come out in the dichoptic format, so you may just be passively watching a movie with a slightly different stimulus being presented to each eye. So the vision therapy system 4 is the one which we have the longest experience with. It provides dichoptic targets using a LCD stereo TV with liquid crystal shutter goggles. The issue with this is, of course, that it is extremely expensive, especially criticism against the goggles were that they get damaged easily with children and they are difficult to replace. Plus it is an in-office therapy, so again accessibility is a major issue. So dichoptic basically means you're separating the images which are being presented to each eye. Now this has been done, computer-based therapies are available like this, where the dichoptic effect is provided by using red-blue or red-green glasses. So as we saw in this video, the background and certain objects in the background are in one color, blue. for one eye, and the moving targets are of a different color which can be perceived with the other eye, and the task can be completed only if you're using both the eyes together. So we've been using one of these therapies, neuropy, for a while now. I have 20 patients, mean age of about 15.1 years. Even in this, about 40% of patients were lost to follow-up, in the sense the entire therapy, about 40 to 45 minutes a day, lasts for about 5 to 6 months, depending on how regularly they do it. And 40% of patients did not come back after 6 months, so we don't know what the final visual acuity is like. But in those who did follow up, we did find an average of 1.5 line improvement in vision. But again, this group generally tends to be very non-homogeneous, in the sense they may be detecting it at 13 years of age, you're starting glasses for the first time. Some of them are combining patching as well because they want to try everything which they can. So we really don't know if it is the effect of the therapy or not. And virtual reality based vision therapy is aiming to overcome some of these shortcomings. So this is a company called Vivid Vision, again a dichoptic based therapy, where you divide the two eyes. You have one scene for the weak eye and one scene for the strong eye. You increase the signal strength, so a stronger image for the weak eye and a suppressed image for the stronger eye. And gradually these images are equalized as the vision improves in the weaker eye. And this is how it actually works. You wear a virtual reality headset, and it's pretty much like playing a game. Inside the virtual reality headsets, you're provided targets which you have to shoot using both the eyes together, and the background is common between the two eyes. Luminopia 1 is a new therapy which is being launched this year. It has been FDA approved. It's getting a lot of push from prominent pediatric ophthalmologists in the US. Basically how it works is the therapeutic visual stimuli is provided by real-time modification of TV shows. So these may be things like Sesame Street, which the child is already familiar with. And you wear the headgear, the virtual reality headgear, and you can select what shows you want to watch. And you do that for maybe 1 hour a day. This is a recent study which was published by them for 51 patients. They wore glasses plus 1 hour of Luminopia 1 therapy a day for 6 days a week for 12 weeks. The control group only wore glasses. There was no therapy, no patching. They did say that the visual acuity improves by 1.8 lines compared to only 0.8 lines in the comparison group who are only wearing the glasses. And finally, this is a system, the orthoptic magnocellular stimulator devised by Dr. Santan Gopal. This works on the principle that patching works from a bottoms up principle, which means that the eye goes and stimulates the brain, whereas he feels that stimulation of the magnocellular cells and the overt and covert attention mechanism increases the top-down impulses from the brain, from the posterior parietal cortex, which increases the lateral occipital activity. He's reporting extremely good results with this therapy, and I know a lot of these devices are now being used all across India. So I think we'll have more data maybe in 6 months or so to see how effective it is for different kinds of amblyopia. And finally, I want to conclude by saying that we still need to look at the child as a whole and not just the eye, not just the amblyopia. Many of them have multiple disabilities which may include walking, which may include hand-eye coordination, several learning disabilities as well. So rehabilitation involves medical, social, educational and vocational measures for training the child to the highest possible level of functional ability. Thank you so much.
Thank you so much. And thank you for that excellent presentation. I would now request Dr. Meenakshi to set up her talk. And really, I'm very happy to have her in my course for the first time. Last time she couldn't attend. And she has been a teacher of teachers at Shankar Netralaya for several years, and I indirectly am her student. My husband he claims being one of her pet students, which I'm sure is not true, but but while madam is setting up and talking to us about the paradigms for squint, Varshini, I have a question. I mean, I'm more of a cataract surgeon and a pediatric cataract surgeon. I'm not very good at these newer modalities for visual rehab. Now, a lot of parents come and ask us that, is there any mobile game? Is there something we can do? So what would be those 1 or 2 things which are maybe a cell phone game, or Other than patching, what are the top 1 or 2 things which you would recommend in these?
Or in other words, commonly they ask, my child is looking mobile, please tell him not to use it, kind of thing. So what's your advice? Now tell us. Is it good or bad?
So,
Because we are loaded with every other patient or mother would say, and they want us, they will prompt us before.
You
to
tell
bring-
them,
when
you
I
tell
bring it,
them.
Please tell them not to use
Not
the
to use.
mobile.
Yes, I think that is true.
So what we usually advise is mobile phones definitely, I mean, playing games definitely helps them in focusing. So we do say that while patching, you know, if you're doing 6 hours of patching, obviously they're not playing the mobile the entire time, but if they patch properly, you can let them play games for the last 1 hour of patching. So which is a reward at the end of proper patching. So it's something which the child looks forward to as well. And to answer Dr. Vaishali's question, there are some games which have come out with a dichoptic variation. The red blue glasses which I mentioned, they're very cheap. They are available on Amazon for about 400-500 rupees. And these games, especially there's one very popular one called Tetris, which is available on the iPad, and I think there's an Android version as well. So it's called Lazy Eye Tetris. And it's played with these blue-green. So again, some of the blocks, it's a falling block game basically. And so some of the blocks are red and some of them are blue. And that is what I suggest, like when they ask, is there something extra which we can do? Because it's very simple to do. You just download the game, it's free to download. The glasses are available off Amazon to order. So I tell them that they can do that along with the patching. But generally, I'm still.
You're not answering my question. If they are not patching and if the mother tells you, please tell my child not to use, how do you handle that? It's so common. I want to learn from you, the mother.
So the normal children, I tell them they're not touching the phone, that their phone needs to
Why
be
not?
kept
Why not? You said it's
kept away. No, for the children who are patching, yes,
No,
I
but
do advise that
what
they.
is bad about using
So we are having a lot of issues with mobile phone usage. So that is not entirely related to amblyopia, but some forms of squint, especially accommodative esotropias. I think Dr. Leela Mohan will agree with me. The incidence of strabismus has.
I think she wants to say that's the other instruction course. the one about
No,
excessive
so that has
smartphone use.
increased massively. So we definitely discourage.
Thank you. Yes, next.
Thank you so much, Dr. Vaishali. I feel very honored to be here. And this is very special because as I was watching the videos, I felt I was again at the side scope watching my teacher, Professor Jagat Ram, from my PG days. And Dr. Vasavada is a good friend. And Vashani is my PG and fellow. And there are other fellows and friends in the audience. This makes it very special. And there is a PG too, but I suspect he has come to listen to his wife and maybe take a selfie with me at the end of this. But thank you again for making me part of this. Now, you all saw some fascinating videos. And then Varshini told you how to get the vision back with amblyopia treatment. What if there is a coexisting strabismus? Don't you want ultimate both cosmetic and functional vision, functional outcome for your patient? That is where management of strabismus comes in. Now, I've been a teacher for 20 years, so I will warn you that some of my talk is going to be as if I am teaching you, and some of it will be as if I'm giving you some take-home message, because there is paucity of strabismus management articles which made me think of, that maybe we should look at our own data. Your data, our data. We should look at it to see what are the strabismus management outcomes in pediatric cataract. There's hardly anything out there. So let's start off with some basic figures. How common is strabismus in children with pediatric cataract? Well, at least the reason why strabismus happens. So I'm only going to cover a couple of articles. This one is from Israel, when looked at strabismus developing after unilateral and bilateral cataract surgery in children. And their findings said that strabismus was found preoperatively in 1/3 of children and was present in significantly more children at the last follow-up. And remember this, strabismus developed in almost 50% of children who were orthotropic preoperatively. Why is this important? Because you may have to have that conversation with the parents that, look, everything is not over. We have heard enough of that it's a lifelong follow-up, as Professor Jagat Ram said, because not only are you going to be managing visual axis obscurations, you're going to be managing pressure, but you're also going to perhaps manage a new onset strabismus, and you need to warn the parents about it. And 1/3 of children who had strabismus before surgery became orthotropic. Magic, that may happen too. So tell them good things may happen, but new things may happen as well. So if you look at what factors increase the chance of postoperative strabismus, your parent asks you, will my child get it? Will my child have a new problem? Well, if unilateral, yes. And if it's a younger age at the onset of cataract, again, yes. Okay, then we come to the other question, always the $1,000,000 question. Does implanting an IOL solve the whole thing? At the last follow-up, strabismus was found in 46% of aphakic and 58% of pseudophakic children. Not really significant, so implanting an IOL is not going to prevent strabismus from happening. Now, let's look a little bit at an Asian study. And this one came out of Korea. And in their study, we all the time thought this was esotropia that's going to be common. No, in their study, they found both preoperative and postoperative exotropias were more common. Coming home to an Indian study, and this is really the only one I came across, and if you have any of your already published, let me know, because I looked long and hard. So this study that comes out of Drashti Netralia looked at strabismus in cases of cataract in pediatric age group, a really large study, and they talk about orthoptic treatment and things got better. But yes, they also found that at the end of this study that children did very well with orthoptic treatment. And nothing like an RCT, and of course we have the infant aphakia treatment study in which they looked at the 1-year strabismus outcomes. And what did they find? That there was no difference whether an IOL was implanted or in the contact lens group. But the younger age of surgery, less than 49 days cohort, did show lesser incidence of strabismus than the older cohort. So if it's a take home, if you want less strabismus from happening, choose earlier surgery. Why is a new onset strabismus significant? Here you've done cataract surgeries, the outcome is beautiful, you've done a superb job. What does a new onset strabismus tell you? It could also be that visual axis opacification or obscuration is happening. And now you have an added amblyogenic factor. You already have deprivational amblyopia. Now you have strabismic amblyopia on top of it. Remember, these children are really young. And of course, that leads to loss of binocularity. So in this day and age of medical legal problems, what I say is take an external photo before cataract surgery with the child awake so that you and the parents all know that there was a pre-existing strabismus. So we go on to how are you going to manage? Now there is a strabismus. What are you going to do? How are you going to manage? First of all, don't rush into anything. Wait. Wait till the primary surgery follow-ups are completed and you're satisfied that the refraction is stable, or at least as stable as you want it to be. Make sure the best refractive correction has happened. For example, if it's a child who has a traumatic cataract or a unilateral developmental cataract, you have decided not to implant. Make sure the contact lenses are adequate, secondary IOL is in place, and adequate amblyopia therapy has been given for long and hard, just like what Dr. Vaishali was talking about. So these are the first things which never changes in any strabismus management. Appropriate refraction, refractive correction, and adequate amblyopia treatment. So when you do plan the strabismus surgery, a few things to keep in mind. You would like to do a limbal approach, spare the superior conjunctiva for anything glaucomatous that needs to be done later. Plan for orthotropia. I say this because as strabismus surgeons, many of you here in the audience, we like to overcorrect certain situations and see whether the eyes will drift into ortho. I don't think we should aim at all this for these patients. You want to be realistic with your goals. Remember, very often these children have thicker corneas, so postoperative IOP measurements, steroid responders, some things to be kept in mind, that you have to know what the pachymetry is. And also be aware of other cosmetic issues that may coexist. And what do I mean by that? Sometimes you will have these children coming to you at a later age for strabismus correction when they're going to start high school or college or go for a job. And sometimes you will find that the posterior capsular opacification is much more visible now once you correct the strabismus. So you may have to fit these children with a cosmetic contact lens, because it is a holistic, it's the whole deal. You're going to make the child functionally better, cosmetically better. So you have to pay attention to that. In conclusion, evidence shows early intervention reduces strabismus incidence. Amblyopia therapy is crucial for good strabismus surgery outcome, and a holistic approach taking all cosmetic and functional considerations is important. Thank you.
Thank you so much, madam. And I think what came out from this while Dr. Leela is setting up, please, is that one, like madam said, discuss. I really was myself, sort of taking that picture and have a record of the strabismus and discuss it with the parents that you are going to need management or that something new might come up. And the other fact which madam very well highlighted, most of us, we just check vision, we check refraction, none of us focuses so much on binocularity or stereopsis assessment, distance and near. So I think these are the things that need to come up more in our assessment so that we can probably plan their management and surgeries much earlier.
What I used to do, I don't see the children very much these days, but I would always say, even if the eyes are absolutely orthoptic, perfect, I will bring it to the mother. I think this eye is a little bit squinting, don't you think so? And she cannot not agree with me, a little bit, because I just wanted to cover up. That's a trick I used to do every time I see a unilateral cataract. Even if the eyes are straight, I would sort of raise a question. I think there is some degree of squint, because I know that it can develop. Yeah, that's right. So this is a practice trick. I did it. Now I don't see the children that many, so I don't know what's happening here. But that's something. The point Meenakshi made it very correct. Almost 50% of the children will develop squint. So tell them well in advance, counseling, as we do in adults, that you will have a glasses and you will see halos, and whatever we do, apply the same thing if you're doing a child.
It was a very nice presentation by Dr. Meenakshi, and she is absolutely right. We have to tell parents that there is a squint, because otherwise they will say that there is a squint after surgery. So I think that point is very well taken, because number of children having squint after surgery may increase by 10 or 15%, as shown in the study, 48 to I think 58% or whatever. So I think we have to tell before that there is a squint. Otherwise parents will blame that previously you never told this thing, and there may be definitely I think we have to highlight this point.
But there is if you don't mind 1 minute more.
No, sir.
Sometimes which eye is squinting? I have no clue which eye is squinting. So I say, well, sometimes you see, do you think this one? Well, I think the other one. Or maybe sometimes it does that. But make sure that you utter a word called squint. That's the fundamental thing, okay? Right, okay, go ahead.
There is nystagmus also. Many of these children, they may have nystagmus also. That also should be highlighted कि आपके बच्चे की आँख तो ऐसे हिल रही है ना, और इसमें vision कम है इसलिए हिल रही है. You have to tell that. Because that is a sign, squint, and this is sign that vision is poor.
Also, we need to highlight that both squint and nystagmus are not going to be affected, at least positively, in a good way after surgery. I think parents expect all-in-one solution, so we need to tell them that this won't change in most cases. And now, next to our last, but probably the most important keynote lecture for this course, our very dear friend, Dr. Leela Mohan. Thank you, madam.
Thank you, Dr. Vaishali, for giving me the space. In fact, I would have loved to sit here and listen to all these stalwarts. Vasavada, Dr. Vasavada, I've seen him put all what he is teaching into practice, being with him there. So my teacher, and he gave me the courage to do some pars plana vitrectomy, which I don't routinely do, but I started after seeing him. And though all Dr. Meenakshi, Dr. Jagatram probably may not know that I have been learning from all of you over the past years. I don't know what more I am going to add to from whatever we have heard here, but I'll just present whatever I have learned from them. So there is nothing more updated, in fact. So over the years, from 70s to 2000, lot of things, viscoelastic, posterior capsulectomy, vitrectomy, CCC, newer IOLs and triamcinolone assisted vitrectomy, and all have made IOL implantation possible in younger children. But further, the goal of surgery, of course, we know is clearing the visual axis for the retina to mature. But further follow-up of visual axis opacification, IOP, refraction of the growing eye, and isometropic amblyopia, all are our unpredictable challenges. And most of these, all the gray areas have been discussed in detail. Well, how early to implant an IOL, whether what to do for visual axis opacification, and whether we should do anterior vitrectomy at all, and IOL power calculation, and whether premium lenses are advisable. So it may all come down to timing, as we have already said. The child loses one line of visual acuity for every 3 weeks, that the surgery is delayed in the first 14 weeks of life. And unilateral cataracts are best operated, as we know, at 6 weeks, and bilateral by 8 to 10 weeks. And once nystagmus sets in by a delay beyond 3 months, visual outcomes are poor. And we know that aggressive patching can improve even in unilateral cases. And of course, we know that even unilateral and bilateral cases nowadays, infection has a very big brunt on the causative issues. Though genetics, of course, is 25%, and it used to be rubella on the holding upper hand, but we have seen that CMV is coming up nowadays, and in spite of government efforts to control congenital rubella syndrome, it is a persistent public health problem in India now. And studies have from LVPI, Dr. Ramesh and Dr. Vivek all have shown that CMV has a big role, and that 33% of the causative factor is infections. And in our study also, we have seen from 2012 to 2017, CMV has become the major infectious cause rather than rubella. And of course, the associated microphthalmia, cornealopasty, glaucoma, and anesthesia, of course, has a very big issue also. Surgery may have to be done within a day or two after cardiac surgery, and modern safe anesthesia has made surgery possible. But we have to keep in mind about the hypothermia, hyperthermia, all these problems can occur and may need an ICU management, which we have to do. And ophthalmic evaluation, of course, has already pointed out the recent intraoperative OCT may be useful in knowing the integrity of the posterior capsule and mitriolenticular interface dysgenesis, and plan surgery accordingly. And all others, of course, in assessing and deciding whether IOL can be implanted or not. And surgical issues already discussed here: anterior capsular access in a closed chamber with trip and blue and viscoelastics, and nowadays the intracameral use of epinephrine has made it easier when the pupil comes down. And rubella cataract with a microphthalmic eye and small pupil, the calcific capsule can be, sometimes it may have to be removed also with a forceps, but anterior and posterior vitrectorexis may have to be done in these cases. And other methods for precision in capsulorhexis are zeptorhexis, which I am not very fond of in children. Even in the older people, I am not very comfortable with that. But it is said that even in small pupil, it can be done. And femtorhexis, as already pointed out by Dr. Vaishali, that the both anterior and posterior rhexis have to be of the same size, but some correction factors have to be made for the enlargement of the rhexis, which can occur in the elastic capsule. And in the bag, a bag in the lens may be better done with the femtorhexis. So this from through a limbal approach with a 23 gauge vitrector, but it can be done pars plana too, especially in microphthalmic eyes where we are not planning for an IOL. And CME, though not documented, it's not a common. It's not common by FFA studies as shown by Morgan et al. And after vitrectomy, I forgot to. So I don't want to waste more time. The conventional PPC with anterior vitrectomy versus posterior optic capture, as we have already discussed, randomized control trials have been done in India by Dr. Vasavada and also Dr. Sukhija, Dr. Jagatram, showing that comparable results have been are there even without vitrectomy. So that may be the conventional method in future, we don't know, because implications of doing doing vitrectomy in that early period has been well highlighted. I've heard Dr. Vaishali speak on that extensively before. So we don't know that that may be the way to go. Bag in the lens is another way to prevent visual axis opacification, and where the anterior and posterior leaflets of the capsule are tucked into the groove of the lens. And the role of central corneal thickness. Phakic eyes, as we have seen, has shown to be have an increased CCT as compared to those who had primary IOL implantation. In all the studies, the role of vitreous factors which might alter the microstructure of cornea and angle are still not known. They may play a role on in glaucoma development, and there may be a false increase in glaucoma also. Glaucoma diagnosis if this is not taken into consideration. A lot of studies have done on this, but not extensively. We don't know much about it, whether the vitreous vitrectomy has a role on that. And we have already seen unilateral cataracts, primary IOL implantation in unilateral cataract is to prevent periods of aphakic vision. So though IATS has shown that membrane formation and resurgery had to be done, long-term outcome was similar, and compliance with contact lens, as they have used about 9 to 11 contact lenses in a year, which was provided by the study, which is not possible in our situation. So probably we may have to consider IOL implantation in a normally formed eye with the normal parameters of cornea and anterior and posterior segment. So as Dr. Vasavada had already pointed out, and Dr. Jagatram was saying, that posterior plaque, I believe also that it is due to posterior capsular opacities, and posterior plaques may be due to PFV. And we have seen in unilateral microphthalmic eyes, about 60% of them are due to PFV, and posterior capsular plaques are seen in 60% of these microphthalmic unilateral cataracts. So a good outcome has been possible in most of the anterior forms, where this is a single piece IOL. I would prefer also multi-piece IOL to capture, but here I have done single piece with posterior capture, and primary IOL implantation is possible in most of these cases. And if there is a heavy vascularization, this is a retinal endocautery being used, which is very useful to prevent bleeding. And most of these cases, when it is very vascular, previously I used to ask the posterior segment surgeon to take over. But now with the endocautery, I am doing it. So posterior persistent fetal vasculature, of course, we have to do an extensive detailed examination, and it is better tackled by the posterior segment surgeon if it is very vascular. And whether IOL or not, as an extension of IATS, we know that the toddler aphakia and pseudophakia studies have come up. TAP study has shown that IOL is a safe option in unilateral and bilateral cases above 6 months with low visual axis opacification and glaucoma. A study on 100 eyes of infants by Sukhija et al. And Dr. Jagatram, as we have seen, is has been shown to be safe, and from LVPI also. Of course, IOL power calculation, and we have been already discussed in detail, and which IOLs can be used, single or multi-piece, hydrophobic the best, and multifocals are best avoided during amblyogenic years, and toric IOLs may be considered in the older children if it is possible. And secondary procedures, the age of secondary IOL should be customized according to whether the patient is using aphakic glasses or not. and 3-piece hydrophobic IOL with optic capture will be the ideal. And membranectomy, glaucoma, strabismus surgery, all will have to be considered over the years, and large anisometropic myopia with a very large anisometropia, sometimes IOL exchange may have to be done. And whether primary IOL implantation protects against glaucoma, there are various studies showing conflicting results. In the 10-year follow-up of TAPS, sorry. Both groups have shown that an incidence of 23% glaucoma, irrespective of whether it was primary IOL implantation or phakics. So whether it is the barotrauma to the immature angle at the time of surgery, whether it is due to vitrectomy and vitreous disturbances, all these have to be followed up, and follow-up with ASOCT might help in answering some of these questions in the long run. And of course, as everybody has stressed upon, the follow-up is the most very important factor. And even before planning surgery, we have to tell them, unless you come for follow-up, there is no point doing surgery, clearing the media. So all these have to be seen at each visit. A red reflex is essential, fundus, slit lamp, visual acuity, refraction, and axial length and corneal diameter, if necessary, examination under anesthesia. And a good chair time during counseling, during each time they visit you after surgery, is very important to make them come for follow-up. This is what I have seen, because over in Malabar, where I stay in Kerala, there are a lot of people coming from Gulf, and they do surgery and just disappear. So it's a pity when they come back with a lot of these problems. So it has to be stressed. The follow-up is the most important. Each time you have to stress the importance of follow-up. Thank you so much. Thank you, sir. Thank you all of
I have
you.
a question. When they disappear, when they come back,
to
no,
Gulf.
this is the lighter side.
They-
Wait a minute, this is the lighter side. When they appear, do they bring some gold with them? Thank you.
So thank you, Dr. Leela. This was, I think, all in all, I had a very good time during this course, and I thank you all for being with us throughout on this last session of a nice Friday evening in Bombay. And I cannot thank my faculty enough for agreeing to be part of this and teaching us so much. So thank you all, and I think a special shout out to the person who was managing this hall. In the world, I have never seen anywhere somebody serving you coffee, like asking you. So this is, I think, hats off to the LOC and hats off to him. Thank you so much.
I think he's the best person who has, I think, for the first time I have seen in any of the hundreds, more than 500 conferences, I have seen, I think he's the first person who offered tea. And in Bombay, it is a big thing.
Also, even in Bombay.
Even in Bombay.
No, but before we sit, because we already overshoot, let me have two more. I want Professor Jagatram to say final 2, 3, 4 lines of pearls of wisdom from pediatric cataract surgery. You're the most.
No. I think I consider Dr. Abhay Vasavada my teacher and my guru and mentor, and he is inspirational for me, whatever I have learned. What I can say that young children, particularly less than 6 months of age, we have to be extremely careful, and whatever very selectively one may implant in some cases, but not as Dr. Vaishali Vasavada said. I think we should follow that. That is one. Second thing is micro-ophthalmic, I do not use IOL. That is another. Third thing is surgery is the first step. Follow-up is important. Counseling is extremely important. And most important thing is that these children, they have squint. As Dr. Meenakshi also emphasized, we have to highlight that, which we ignore most of the time. And parent will say that this squint has appeared after cataract surgery. And our another speaker, Dr. Varshini, also very rightly said the patching, that is extremely important, amblyopia therapy. That is extremely important. I think otherwise vision will not develop in these particularly unilateral eye, and sometime even in bilateral eye if there is a anisometropia. So I think this was excellent instruction course. I am thankful to Dr. Vaishali Vasavada and Dr. Abhay Vasavada for giving me opportunity. Thank you so much. And thanks to the audience. They are here till last.